Listening Part A. You hear a specialist physician talking to a patient called David Johnson. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
It's nice to meet you, Mr. Johnson. You've been referred to me by Dr. Bruce. Why don't you tell me why you're here?
About a week ago, I was in a car accident. Nothing really happened at the time. I spoke to a doctor that day, but he was still a bit concerned. So a couple of days later, I think it was about that, I definitely started to feel a little bit different.
So what happened when you first went to the doctor?
Well, right after the accident, there was really no problem. I didn't feel anything. It didn't hurt at all. He did say, the doctor he said that I should just watch out or pay attention to see if I had a sore neck or sore back or anything. And that's what happened. A few days later, I was starting to feel a little bit dizzy. And then, that's when he said it was definitely whiplash, and he referred me to you.
Okay, and so how have you been feeling since then?
Well, I've definitely had a sore neck. It's really been bothering me the last day or so. And like I said, I've been feeling a bit dizzy. Actually, I have to sit down once in a while because it gets a little disruptive, difficult to work and that sort of stuff. I've been feeling a bit sick too. I actually had to take yesterday and today off work because I'm finding it quite difficult. I've been really tired as well.
Is there anything else in your medical history that I should be aware of? Any allergies or any other recent visits to the doctor?
I don't think there's anything that pertains to this injury. I am allergic to penicillin. I just found that out recently, actually. That could have been quite dangerous. And last year, I had the flu really, really bad. But nothing that really relates to this.
It says here you play hockey.
Yeah, every weekend.
Any injuries that I should know about?
Not really. I've been pretty lucky, actually. A couple of months ago, I had a sprained ankle, which is pretty common in hockey. We usually have good trainers, though, and they keep an eye on us. We also take good care of ourselves.
Nothing serious, then?
No, I've been pretty lucky.
And just take me through your family's medical history.
Let me think about that. There's hypertension and heart disease. Those are two things that have been there for my grandparents and my parents. My parents actually take it quite seriously, so they're eating a lot better these days. I do as well. And my grandfather had a stroke a few years ago. That was pretty hard, and now he's showing some early signs of Alzheimer's.
Okay, well, I'd like to examine you in a minute, but first I really need to make you understand you're going to have to stop the sports for the moment.
Oh, really?
Uh-huh.
That's kind of a tough one, Doctor. Sports are a pretty big part of my life. I really don't know how I feel about, it's pretty tough for me to sit still, and we have to do this big hockey tournament next week. Is there really no way I can play in that? I can take it easy when I am playing. There's got to be a way I can get out on the field. I've been working toward this all year.
Well, I can't stop you from playing, but I strongly advise against it because if you get hurt, you can cause some permanent serious damage. So you really need to rest and stay off your feet until we know what's causing these symptoms.
What if I'm feeling okay by next week? Would it be alright to, play then? If that was the case, You're a doctor talking to a patient called Mrs. June Wilcox. For questions 1 to 12, Complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
So, Mrs. Wilcox, your GP referred you to me because you've been having a bit of trouble sleeping. Why don't you tell me what's been happening?
Okay, yes, that's right. I suppose I've always had some trouble breathing fully through my nose, especially through my left nostril, but I feel like it's been worse in the past few years. I used to play a lot of sport, especially netball, but I've had to give it away because I was getting so terribly short of breath. So while it's there during the day, the blockage, it's even worse at night. When it's time for bed, well, sometimes the left side of my nose can feel completely stuffed up. My husband tells me that I've been snoring as well. It started a little over 12 months ago, I suppose. Yes, probably 12 to 18 months.
Do you feel tired in the morning?
I do, yes. Sometimes it can feel like I've hardly slept at all. And the back of my throat tastes like I've smoked a pack of cigarettes. I've tried some of those sprays, you know, those ones that you can get from the chemist, those decongestants, just to try and help clear my nose a bit. They used to work, but then after a while, they all stopped being effective. Then, when I first spoke to my GP about what was happening, she prescribed a spray for me. It's a combination corticosteroid antihistamine spray. It was wonderful. I really thought it was going to fix it right up, but she said I shouldn't really stay on that long term because she thought my issues were more structural. That's why she recommended I come and see you.
Okay, great. Do you mind if I take a look? This won't hurt, but it will allow me to confirm your GP's diagnosis.
No problem.
Okay, thanks. Well, it definitely looks like you have a deviated septum, and you have some quite large turbinates as well.
Right, okay. That's what the GP said, wasn't it?
Yes, it isn't so unusual. Almost no one has a completely straight nose. The issue is that yours is affecting your breathing, and that's making it harder for you to sleep.
Yes, that's right. Can it be fixed then?
It can, yes. The best option is usually a very simple surgical procedure called a septoplasty.
Right, I see. Surgery. I'm not so keen on that. The only other time I had surgery was on my knee, and it wasn't very successful. If anything, I think it actually made it worse.
Well, septoplasty is very successful and very common. It will allow me to straighten and align the cartilage structure that exists in the midline of your nose, and you'll find you'll be able to breathe much more freely after that.
I just don't know if that's the way I want to go.
There are other options we can try, perhaps less structurally invasive. I can outline some of those if you like.
Yeah, I just don't know. I can suffer with a bit of anxiety sometimes, you see. It's something I've had to battle with for a while now. I suppose I'm just a little worried that if we decide to go ahead with surgery, I might have some sort of panic attack, you know, on the day itself. I just don't know what I should do.
B. You hear a nurse and a senior nurse discussing a patient. Now read the question.
Joe is doing much better today.
Well, that's good to hear.
Yeah, he's just done his 9 o'clock exercise session. He's got normal movement in his right shoulder now. He performed both rotation and flexion exercises very well.
What about the hip exercises?
He can do the abduction and the extension exercises, but he still has a lot of pain in his right hip. And as for exercises for the left shoulder, he can only do the shoulder flexion to 100 degrees, and he can't do the shoulder extension exercises at all for the moment. I'm just writing up the flow sheet now. Do you need any other information?
Listening Part B. You hear an optometrist talking about amblyopia to parents and teachers at a kindergarten. Now read the question.
I was asked here today to provide important information regarding amblyopia in children. Amblyopia is a condition in which the nerve pathway from an affected eye to the brain is not properly developed during childhood. It is the most common visual impairment among children and affects up to 3% of the young population. However, because only one eye is usually affected and the other eye does the work of both, many parents are unaware of the problem. Fortunately, it can be easily detected with a thorough eye examination, and the earlier the condition is detected, the easier it is to treat. Treatment depends on the particular cause of amblyopia. However, most commonly eyeglasses, prisms, and eye drops or patches are used to blur the vision of the normal eye and force the brain to recognise the image from the eye with amblyopia. Now, the government is offering free eye tests at our Centre for Medical Care Holders, so I urge you to take advantage of this offer.
Listening Part B. You hear a nursing lecture talking about side effects to a group of student nurses. Now, read the question.
Today, we are talking about side effects. We'll look at the most common drugs first. As you know, some patients suffer side effects and others don't, and not all patients suffer the same side effects either. Let's consider ibuprofen, for example, a very common pain medication. Some people may suffer dizziness, and others might feel nauseous. It's also possible to have diarrhea, vomiting, even headaches with this type of pain medication. Injecting drugs intravenously may cause swelling at the injection site for some patients. Stomach aches are a side effect of some anti-allergy drugs, as well as loss of appetite and constipation. Patients who take Valium may experience drowsiness, while others may get a rash. Tremors are another side effect of this drug.
Listening Part B. You hear a senior registrar talking about cholesterol to a group of junior doctors. Now read the question.
The average total cholesterol level in the UK is 5.5 millimole per litre for men and 5.6 millimole per litre for women, which is above a normal level. So does that mean that most people need to take anti-cholesterol drugs? In recent years, we've come to realise that to decide whether an individual's cholesterol levels are dangerous, these levels need to be considered in the light of the person's overall risk of heart disease. This overall risk is determined by a combination of factors, including age, gender, family history of heart disease, and whether someone smokes, is overweight, has high blood pressure or diabetes. The higher the risk of heart disease, For example, a male smoker with high blood pressure and diabetes, then the greater the need to get cholesterol levels down.
Listening Part B. You hear an agency nurse checking his schedule with an employee at the agency. Now read the question.
Hi Karen, it's Tyler Brewster. Are you able to give me my schedule for this week?
Sure. Is the afternoon shift okay for you?
I have exams in the morning, so the afternoon shifts are perfect, yeah.
Okay. So you start on Tuesday at 16:45 and finish at 2300. On Wednesday, you start at 15:30 and finish at 22:15. It's the same on Thursday.
Oh, that's good for me.
Are you free on Friday? I need a staff nurse for St. Peter's Care Home in Hillsworth.
I'm not free on Friday, no. But Saturday? I can work on Saturday if you need me.
Saturday. Can you do a shift at the Amazon Hospital?
No problem. What time's the shift? Listening Part B. You hear a conversation between a senior nurse and a student nurse. Now, read the question.
If you give an injection, always throw away the needle in the sharps box here.
What about the cap?
Never recap the needle, just drop it in the box.
Why?
So you don't injure yourself with the needle, and we have a special place where we throw away the sharps boxes. If you want to throw away other material like gauze or surgical tape, never put them in the sharps box. Sharps boxes are very expensive, and we have a special waste room where we throw them away.
Okay, I understand.
And if you take blood, always use disposable gloves. And in the OR, if you pass sharps like needles and knives, never use your hands. Always use a tray.
Listening Part C. You hear an interview with a dietitian called Ellie Parr on the topic of belly fat. You now have 90 seconds to read questions 1 to 6.
جيبها رايحة تقتل جيبها
My guest today is Ellie Parr, a dietitian and associate professor in nutrition at Deakin University. Ellie has been speaking recently about the dangers of belly fat. So Ellie, tell me, why are you raising awareness about this issue?
Well, Australians are getting fatter, and there's no dispute over that fact, and the fact that this increasing weight is affecting our health. Excess storage of fat is linked to many different chronic diseases, but some areas of fat storage on the body are worse than others. In general, women have greater absolute body fat percentages than men. Typically, women carry more fat around the legs, hips and buttocks, as well as the chest and upper arms. Women have more subcutaneous fat, the fat that you can pinch under your skin, while men typically have more visceral fat, which is stored in and around the abdominal organs. People who have greater fat stores around their buttocks and thigh regions are at lower risk of chronic disease than those who have greater fat stores around their middle.
Why is belly fat more dangerous?
Well, researchers have found excess visceral fat storage is a significant risk factor for metabolic health complications of obesity such as type 2 diabetes, fatty liver and heart disease. Fat cells in a healthy person are able to grow, recruit inflammatory cells to help reduce inflammation, and remodel themselves in order to allow for healthy body growth. But if there is excess fat tissue, these mechanisms don't function as well. And with excess fat, the body can become resistant to the hormone insulin, which maintains our blood sugar levels. Visceral or belly fat secretes greater levels of chemicals that trigger inflammation and releases more fatty acids into the bloodstream. Whereas the fat cells in the leg region and the pinchable subcutaneous layers of fat around the middle store fatty acids within themselves rather than pushing them into the circulation.
Do you think most people should just try and lose fat from anywhere?
So a recent weight loss study that looked at where fat mass was lost found that areas of fat loss didn't change the risk factors for heart disease and stroke. The important thing was losing fat. While diet and exercise are unable to specifically target regions of fat deposits, fat mass loss from anywhere can improve the risk factors. Online advertisements might tell you that a magic workout machine will reduce fat in one particular area, but we can't target fatty tissue the same way that we can target a specific muscle group. Total loss of fat through healthy diet and exercise is the best outcome for overall health and reducing either the symptoms of chronic disease or the risk of developing diseases such as diabetes or heart disease.
I see. And what do you mean when you say a healthy diet?
Well, if we look at just two key elements, carbohydrates and fructose, carbohydrates provide a quick energy supply that's easy for the body to use, but the body and brain don't need carbohydrates. Your body does need glucose, which can be obtained from carbohydrates, but glucose can also be obtained when it's converted from protein and fat. This means the lower your carbohydrate intake, the more the body uses fat for energy. Fructose, which is found in fruit, is something you should definitely avoid if you want to help your body get rid of fat. It's true that fruit can be good for your health as it contains fibre and vitamins, but to lose fat from around your body, it is important to limit the intake of fruit. Fructose activates an enzyme which activates other enzymes, causing the body to accumulate fat.
What about those who do eat well but still can't lose fat from around their belly or anywhere else?
Well, if you sleep for less than 6 hours a night, that can certainly be a contributing factor. There was a study done over a 16-year period that took into account almost 70,000 women, and that study found that those who slept 5 hours or less a night were 30% more likely to gain 13 or more kilograms than those who slept 7 hours. Stress is another issue. The stress hormone cortisol has been known to increase the amount of fat a person's body maintains and to also enlarge your fat cells. Higher levels of cortisol have been linked more specifically to increased visceral fat. Age is also an issue. As you get older, your body changes how it loses and gains weight. Both men and women experience a declining metabolic rate. In addition to that, women have to deal with menopause, and if a woman gains weight after menopause, it's usually more likely to be in their bellies.
And what should people do if they're worried about the amount of fat they have around their belly?
Well, remember that not all fat is the same, and some overweight and obese people with a store of excess fat around the middle of the body might also have more muscle mass, which could be protective. However, by the same token, if you have fat around the belly and it's greater than the size of your hips, you should see a doctor to assess your cardiovascular health and fat distribution.
Listening Part C. You hear a primary care physician called Dr. Greg Richter giving a presentation on the subject of secondary prevention of suicide. You now have 90 seconds to read questions 1 to 6.
Hi, my name is Dr. Greg Richter. I'm a primary care physician, researcher and author. My topic today is secondary prevention of suicide. Suicide poses major threats to public health worldwide. In 2002, suicide accounted for about 30,000 deaths in the US alone and almost 900,000 deaths worldwide. This translates to 1.5% of all deaths related to disease. However, I am convinced that these figures can and should be reduced. According to recent research, suicidal behaviour can be distinguished into 4 distinct categories. Completed suicide, where a person has been successful in their attempt to commit suicide. Suicide attempt, where a person has been unsuccessful in their attempt to commit suicide. Suicidal ideation, which is where a person is having suicidal thoughts. Self-harm behaviour, where a person injures themselves deliberately. It is important to realise that 83% of people who commit suicide or attempt suicide have had contact with a doctor within a year of their death, and up to 66% of people who commit or attempt suicide have had such contact within a month of their death. We can divide suicide prevention into 3 categories, which are primary, secondary or tertiary. Primary suicide prevention aims to reduce the number of new cases of suicide in the general population. Secondary suicide prevention aims to decrease the likelihood of a suicide attempt in high-risk patients. Tertiary suicide prevention occurs in response to completed suicides and attempts to diminish suicide in a particular geographical area or in a particular age group. The clinical evaluation of the medical and psychiatric history of a patient and of their current state is the crucial and essential element of the suicide assessment process. It is important because it enables the identification of risk factors in order to assess the patient's immediate safety and the best setting for treatment, and also to develop diagnoses and treatment strategies. Psychiatric illness is a major contributing factor to suicide risk, with mood disorders such as major depressive disorder and bipolar disorder being associated with about 60% of suicides. Indeed, psychiatric disorders are diagnosed in more than 90% of completed suicides, and more than 80% of these psychiatric disorders are untreated. Thus, the recognition and treatment of individuals with psychiatric disorders, specifically mood disorders, are essential components of secondary suicide prevention. In addition, the subjective rating of the severity of depression is one of the most powerful predictors of future suicidal acts. Therefore, assessing and managing depression, as well as being aware of the suicide risks in psychologically, medically, and neurologically disordered individuals, is an important aspect of secondary suicide prevention. Consequently, physicians need to be taught to recognize the association between subjective findings and suicide. Antidepressant medications are the most widely used pharmacological interventions in secondary suicide prevention, but studies of their effectiveness in reducing suicide attempts have had mixed results. Among adults younger than 25, the effect of antidepressants seems to be neutral on suicide behaviour, but it seems to reduce the risk of suicidal behaviour in the elderly. Thus, the relationship between antidepressants and suicide needs further studies before this class of drugs can be safely used for the secondary prevention of suicide. Better psychological and pharmacological treatment of depression and alcoholism also appears to decrease suicide rates. Many studies show that suicides by particular methods, for example, firearms, domestic gas, or pesticides, decrease after the introduction of legal restrictions that reduce access to such means. This reduction in suicide rates is particularly influential in regions where the specific means of restriction correlates with a common method of suicide. For example, in the UK, the reduction of carbon monoxide in domestic gas since 1958 and the reduced availability of analgesics since the mid-1990s have both decreased UK suicide rates. Many studies have also exposed a need for a decrease in reporting of suicide and for responsible reporting. Media blackouts in reporting suicide have coincided with a decrease in suicide rates, because reports of suicide in the media tend to glamorise suicide for vulnerable individuals. However, the internet is of increasing concern, with blogs and chat rooms providing accessible instructions for suicide. Despite our increasing knowledge of secondary suicide prevention, there are still many gaps in the research, and looking to the future, thorough evaluations and appropriate treatments of patients with depressive disorders and other psychiatric illnesses should help to improve the efficacy of secondary prevention of suicide. But it is also clear that more research into new approaches for the prevention and treatment of suicidal behaviour remains essential.
Thank you.